is ready to graduate from high school or begin a job or another important time in their life developmentally. Now, Dr. Macaron will go into more detail about the different types of therapy that are available, but briefly I'll just explain that the different types of therapy services that are offered really would cover behavioral therapy, social therapy, and then psychotherapy. And really the type of therapy that is offered is going to be dependent on the developmental level of the child and or adult with an autism spectrum disorder. Another role that psychologists play is also consulting with other professionals or with schools in order to coordinate services. And finally, and conducting assessments or evaluations, which I'll go into more detail about, just to describe what it is that we do when we complete an evaluation. So when we talk about evaluations by psychologists, there are several different types. And again, they would differ depending on the developmental level of the child and the purposes and needs at that time for the individual. They would cover developmental evaluation for younger children. They would also go into psychological evaluations, neuropsychological, and psychoeducational. And again, really depending on the age and the purpose of the evaluation at that time, we would know how to tailor specifically to that child or adult. Now, when we talk about reasons for an evaluation by psychologists, initially, many parents are seeking a diagnosis or a clarification of diagnosis in order to really know the reason why a child is having difficulties in different areas. So many of you have probably gone through that process of receiving an initial diagnosis and really just having a name, I guess, to the difficulties that your child may be having. Sometimes when it comes to a reevaluation, which I'll go into in a little while, we're really looking to know if a diagnosis is really still a good descriptor of an individual, and also whether or not there's a possibility of what we call comorbidities or other existing diagnoses at the same time as an autism spectrum disorder. We want to specifically determine functioning in different areas. This might cover behavioral functioning, social, emotional, developmental, and finally make appropriate and specific recommendations for different environments, including the home, the school, and also within treatment and therapy to know more specifically how to address the needs of an individual. Now here I'll talk about social and emotional assessment, and just to take a step back, another aspect of evaluations, which I don't have on the slide, but just to review briefly, when we do an evaluation, we're also trying to find out functioning when it comes to cognitive level, really just intelligence or IQ, academic skills, how well the individual is able to process their learning, memory, really factors that are going to be important for academic success. And a part that we also look at is the assessment of social and emotional functioning. We know the importance of social functioning when it comes to autism spectrum disorders due to the nature of the type of diagnosis. We know that social functioning is going to be important to assess. And also emotional functioning, which I'll go into the possibility of other disorders which really will affect the emotional presentation of the child. But one area of functioning that doesn't really receive too much attention but is very important to assess is what we consider to be adaptive functioning. Just to define, adaptive functioning refers to the age-appropriate behaviors that really are necessary for an individual to live independently and to function well within their community. They might include skills within the areas of communication, be able to have a conversation, be able to seek help, to make requests. In the area of self-care, be able to manage one's own hygiene and appearance. Within the home, be able to prepare one's food, be able to clean, manage his or her own money or accounts. Within the community, just being safe and knowing how to follow rules, assessing situations that might be dangerous, the ability to work, and really just to function as an independent individual. And then finally, social competence, so looking at social skills, the ability to make friends, and to maintain relationships in different areas. The reason that we look carefully at adaptive functioning is because it really is one of the biggest predictors of success later on in life and during transition points. And research has found that there is an important relationship between adaptive functioning and intelligence, where individuals, depending on their level of intelligence, actually might have a bit of a discrepancy between where they are intellectually, cognitively, in regards to their IQ, and where they are with their adaptive functioning or their self-help skills. So one study found that for individuals who have autism and higher IQ, average or above, there actually is a big gap between their adaptive functioning and their intelligence. So there's a discrepancy between what we would be able to expect them to do based on their intelligence and what they're actually doing in terms of independent living with regards to their skills. Interestingly, when it comes to individuals who have mild mental retardation, their IQ and adaptive functioning are more or less even. And then within a group with moderate or severe mental retardation, their adaptive functioning is actually better than expected given their IQ or level of intelligence. So in the end, what this is telling us is that IQ is not always the best predictor of success later on. More importantly, to look at is level of adaptive functioning and how that individual can succeed when it comes to taking care of him or herself. Just to go back a second, when we look at an evaluation and we have results, the diagnosis is important to be determined. We're also looking for areas of strengths and weaknesses, which will help us to understand how best to direct services for this individual. If we know that they, for example, have better visual than verbal skills, or vice versa, or if we know that they are especially good in one area, we may be able to use those skills and strengths to really assist them in compensating for other areas where they might be a bit weaker. And then also making more specific recommendations as to what they might need with regards to therapy or other treatments is another important result of an evaluation. Initially, a diagnosis will be important for determining eligibility for services, and these include services within school, accessibility to government programs such as the Medicaid waiver, being able to better understand and communicate with other professionals, guiding interventions, knowing more or less the prognosis or the developmental path that an individual might take, and then also be able to access support such as other families who are affected. Now, what I'll be talking about today is the presence sometimes of, within autism spectrum disorders, other comorbid or coexisting conditions, and more specifically within the area of emotional or behavioral functioning. Now, studies have shown consistently that children or individuals with an autism spectrum disorder, about 70% of the time, also meet criteria for another disorder, most commonly being anxiety, depression, or Tourette syndrome. Within anxiety disorders, an anxiety disorder is diagnosed when you have a disproportionate fear reaction to stimuli in the environment. So in other words, there's something that's perceived to be a threat, but the reaction, the fear reaction, is greater than what would be expected. Typically, when we do have anxiety disorders, the symptoms have an early onset, meaning they present in childhood, and they can become chronic and worsen if treatment is not initiated early. It is more common to see anxiety disorders diagnosed as a comorbid disorder in children with autism, and about 50 to 85% of children with an autism spectrum disorder additionally will meet criteria for an anxiety disorder. Within anxiety disorders, we're looking at both social anxiety as the most common. About 29–30% of individuals who have autism spectrum disorders will receive a diagnosis of social anxiety, which is not altogether surprising given the fact that the social area is really one of the most impaired when it comes to autism. And then we're also seeing that obsessive compulsive disorder is commonly diagnosed as another condition that's present with autism spectrum disorders. Now, when as a diagnostician or clinician, it's important to recognize that the different repetitive behaviors that are seen as part of an autism spectrum disorder will differ from the obsessive compulsive rituals and behaviors that are seen when it's a more pure case of OCD. So it is important to keep in mind within the population of autism spectrum disorders that the behaviors and repetitive interest will manifest differently when there is a coexisting anxiety disorder. Now, depression is another common problem in people with autism. About 1 in 15 children with Asperger's syndrome also experience symptoms of depression. And another study found that depression is more common in children with autism than in children within the general population. So again, it's informative for the purposes of treatment in particular to know whether another condition such as anxiety or depression is also present. And finally, with Tourette syndrome is an inherited neurological condition that begins in childhood and is characterized by both motor tics and vocal tics. It is considered a spectrum in the sense that the tic disorders might be more transient or at a given time, versus more chronic or persisting for a long period of time. And with individuals who have an autism spectrum disorder, 22% also presented tic disorders, so either the actual Tourette syndrome or another motor tic condition. Now, it's also important to consider when we're looking at comorbidities and other diagnoses that many times other more psychiatric conditions such as bipolar disorder, attention deficit disorder, or other psychotic disorders such as schizophrenia are, for one, more prevalent in children with autism spectrum disorders, but it's also a factor to consider that sometimes individuals with these disorders, in particular bipolar or other psychotic disorders, what may have manifested early on as an autism spectrum disorder, as a child develops and matures, may be more clearly defined later in life as a psychotic disorder or as another psychiatric condition, meaning that many times when it comes to the time of a reevaluation, it becomes more clear that what may have presented under the umbrella of autism spectrum disorders in actuality is more clearly defined as another disorder, which would be especially informative for treatment and preparation for a transition time. So just to reiterate when and why reevaluations take place, it really is important to determine the changes in strengths and weaknesses at a given time. An individual, for example, one who was diagnosed early on, may have presented with a particular cognitive profile, and as they get older, the profile changes and allows us to better see areas where they are stronger or better developed as opposed to different areas of weakness. And it also allows us to really determine whether there are other conditions that are existing at the same time or alternate diagnoses. And it also allows us to plan better for transition times, especially for school or for vocational training. Most reevaluations will take place more or less every 2 years, but it's especially important to consider a reevaluation during a time of transition, such as moving from high school to college, or moving from the termination of schooling, formal schooling, to vocational training. It also allows a clinician to determine how effective a particular intervention has been and to update the recommendations, as well as to provide guidance and consultation to parents. With specific regard to recommendations, more along the lines of commencement of services and continuation of services, we're looking to really fine-tune what an individual might need or benefit from at a given point, and within the different services that they're receiving, how best to really guide the intervention. Dr. Macarone will discuss within therapy what is important to consider and how the results of evaluation might inform us as to the goals of therapy at any given time. And in particular, when an individual is at an important transition point, how best the therapy can be used to benefit the individual and the family involved. So with that, I turn to Dr. Macarone.
Okay, so leading into treatment, the therapy part of what psychologists do, we still have to talk a little bit more about assessment. As Dr. Acosta discussed, the issues with assessment are never really finished. It's really important over the course of time that reevaluations are occurring as needed. And I commented that assessment is really more about a lot more than just IQ and diagnosis, as Dr. Acosta discussed. I mean, really, as a treating psychologist, it's invaluable to have a quality assessment done. It really tells us a lot about the strengths and weaknesses and specific needs that somebody has coming in that maybe we wouldn't see at other times when you're just coming in without an assessment. The recommendations, what they tell us a lot is, I get questions a lot about this especially at this age range when we're talking about moving from adolescence into adulthood. The one question I'll get is, do we really need to keep doing therapy for the rest of my life? I mean, is it exist forever? And a lot of times that's what assessment will tell us. And that's one of the things that it answers: is treatment even needed? And if it is needed, then what type of treatment do we need? And along with the treatment from a psychologist, what other services might be helpful given the presentation of strengths and weaknesses that we're seeing in the evaluation. So then we get to treat or not to treat. Generally speaking, we would say that the people with an autism spectrum disorder, we all know that this is something that's a lifelong disorder that's going to be there forever, and so usually the recommendation is going to be that we need to treat. But sometimes enough is enough. Enough is enough. Sometimes, like in reality, there are times where we would say, as psychologists, that maybe treatment isn't warranted. It's unusual, but there are times where that happens, and I'll get into some of those. So this is Discontinue outpatient therapy. The first one I would say is that the value of therapy has been maximized. Now that's kind of a tricky thing, because it's difficult to say that, because as we know that as you're moving through different stages of life, there's different challenges that come up, and in particular with people with an autism spectrum disorder, there's going to be different things that happen at different milestones. And so when I say the value of therapy has been maximized, really I could put underneath that it's, or in parentheses I could say, it's been maximized for the current age range, where the current stage that they're at. Because a lot of times really people will be coming in and they are doing the best that they can do with the circumstances going on around them, and then a lot of times therapy is not needed, and sometimes it could be irritating. It's disruptive, and they have to come in and they don't really have anything to talk about. So in those cases, then I would say that maybe taking a break from therapy would be a good idea. And then if we're transitioning to a more intensive setting, that's obviously also a time where maybe outpatient treatment is going to be discontinued if we're moving to something like a treatment center or something even more intensive than that. However, even in these situations, consultation and guidance is still going to be useful with psychologists. We do a lot of work with these sorts of things, and we're generally able to consult effectively with people like psychiatrists and neurologists and things like that, where it would still be useful to have some involvement. So reasons to continue with therapy, there's a lot. Generally speaking, as you're transitioning from adolescence to adulthood, this is a new stage of life, and there's a whole new set of challenges, as we all know from doing this on our own. It's when the demands go up when you hit 18 and you become an adult, and the expectations change very drastically. And so with these all new set of challenges, a lot of times the life skills that have been learned over the course of time, they're just not going to generalize. There's not because of the circumstances changing. There's new skills that are going to be needed. Another thing I included was that therapy can provide a safe place for support, and I think this is a really important one, in particular when with people in the spectrum that have a hard time with establishing close relationships with people. Once they've got a relationship with somebody that they trust really well, a lot of times these times of transition can be, they really can be softened by having continuation with that person that, like, even on a semi-regular basis, they can come in and even if it's just venting to unload some of the things, some of the stress that's going on with the things that are going on. A lot of times that can be really useful. There's a need for continued learning of cognitive and emotional skills. We're going to get into some of that in a little bit. And then there's other areas that you might not think of when you consider a psychologist, such as I mean, obviously the psychotherapist is the easy one. That's like when we talk about the psychologist, you're thinking of like the guy with the Rorschach card and, you know, how do you feel and all that stuff. But obviously that's the type of therapy that we do with people in the autism spectrum is very different than the traditional type of therapy. But, you know, that's one thing that you think of as a psychotherapist. But, you know, there's other areas that we deal with, like, for instance, as an organizational psychologist, it's an organizational skills trainer. I mean, I don't know if that's really a title, but I know that in our types of treatment, that's a big piece here. That is something that we handle. I mean, things like things from is something that we think of as simple as like managing a planner. To keeping your environment clean around you, to doing different time management strategies and things like that that come into effect, that are things that we have to handle and that the psychologist will handle. I am a life coach also, and I know that there's people that do life coaching as their thing to do. In psychology, as a psychologist, the things that we would be seeing in terms of life coaching are things more like the adaptive type skills that Dr. Acosta was talking about, things that are affecting day-to-day life. This is another area where like things like working on hygiene, paying bills, how you manage things like this that become a much bigger issue as you become an adult, that maybe was handled for you or was being managed for you by your parents before this time. These things become a bigger issue. Some other areas that psychologists do are consultation to other professionals. As I said, you know, working with the 50 million people that are involved in the case. I mean, it seems like there's so many people that get involved with this, from a neurologist to a psychologist to a psychiatrist to if we're dealing with kids that are transitioning. I mean, obviously we're talking about different sets of kids, but if we're dealing with kids that are transitioning to college, then you're also dealing with a whole set of other people that you're having to deal with, like an educational consultant that's going to help with the appropriate placement to different things. Even at the college, the academic advisor and the Office of Disabilities that's going to do that may need communication and things like that. And then I have long-term planning. That's I see this a lot. I've got. I work with a lot of kids in this age range, and a lot of times the idea of the kid going off to college is scary enough as it is. The idea of the kid staying home is sometimes even scarier, because it's like the kids that are staying home are a lot of times lower functioning, and the parent has become used to having the structure of school, and so is the kid. And so now all of a sudden at 21, 22 years old, they have to be out of high school. Then it's like, okay, well, what's going to happen now? And it's some long-term planning as to things like preparedness for work and what kind of position they're able to do. It's really an important thing that comes up in this age range, and a lot of times that's something that we can help with. Just from the notion of what the person's capable of doing, what they're not capable of doing in the long term, based on what we've seen in the evaluation and what we've seen be affected by treatment, becomes a big issue. Working with vocational rehabilitation is something that we do on a regular basis, and then at other times even outside of vocational rehabilitation, I work with people on just different areas where we can maybe even create a position that fits well for the person in the specific skill set that they have. I mean, it's pretty amazing the things that we can do with that. Okay, so there's a bunch of different types of therapy that we would see with young adults with autism spectrum disorders. I'm going to touch on a couple of them that are the most common. being behavioral therapy, cognitive behavioral therapy, and social skills training. Now, I want to specify with this that I'm going to speak about these kind of in their own group, but in real life settings, a lot of times it doesn't work that way. It's not like we're only doing one. There's a lot of times that we're doing pieces that maybe we're doing specifically. We're focusing on one particular style of therapy, but we're going to be pulling from all areas of this, because the reality is that there's different things that these things all do that are effective, and it just doesn't work to just stay on one thing most of the time. So I'll start with behavioral therapy. I'm not going to spend a whole lot of time on this, because by the time you've gotten a kid to 16, 17 years old, and if they're in the autism spectrum, you know what behavioral therapy is, and there's a good chance you've been exposed to good pieces of this. So I'm going to go through it briefly, because one of the things that I get is, like, a lot of times when I talk about behavioral therapy with kids this age, it's the comment that I'll get is, like, people think that it's just that really behavioral therapy is only for, like, little kids. That doesn't work with people who are older, and that's not always true. Let's say in a lot of cases, this is something that is going to be necessary. As I say here, I describe it as we're using modification of behavior, using positive reinforcement, and to a lesser extent punishment to get targeted behaviors. Applied behavioral analysis, ABA therapy, you guys have all heard of. That's one type of it. There's other different types of behavioral therapy. When I say who it's for, primarily we're going to be using this at this age with kids that are a little bit lower functioning. But in some cases, the higher functioning kids are going to be using this too. There's going to be pieces of this that are going to be going in with some of our higher functioning kids. Primarily, it's done by a psychologist or a therapist, often in conjunction with a behavioral specialist in the home. That behavioral specialist can either be the ABA person, or sometimes it's just a behavioral coach or something like that that's in the home. That's often very useful. The goals are obviously increasing age-appropriate behaviors and reduction of maladaptive behaviors. The way it works is we do a functional assessment of behaviors to be targeted, and then we do an implementation of a behavioral plan. Functional assessment of behaviors consists of really sitting down and looking at what it is specifically that we're trying to change. And it may involve sitting with the person and counting the number of times that we see a certain behavior, so that we can have something to look at over the course of time to see what's actually being changed, and so that everybody's really clear on what the goals of the treatment are. Examples of targeted behaviors can be things like repetitive behaviors like laughing, rocking, things like that, table manners, or appropriate use of tone and volume, and obviously we could list up a lot more than that. Okay, now I'm going to talk about cognitive behavioral therapy with young adults with autism spectrum disorders. Okay, so the basics of cognitive behavioral therapy are that the thoughts, emotions, and behaviors are all connected. And the idea of this is that automatic, what we describe as automatic thoughts influence emotions and behavior, and when the automatic thoughts are distorted, they can lead to symptoms like anxiety or depression or other symptoms. Examples of automatic thoughts are it's really like the running dialogue that we have. Like it's kind of the commentary that you have going on at all times of the things that are going on. It could be about the things that are going on in your environment. And the things that we target in therapy really are the comments that we're making to ourselves about things that we do, and the attributions that we make as a result of the things that we're seeing. A lot of times there's a lot of distortions with that. It's not just this isn't just, we don't use this just with ASD kids, but it's been shown to be effective. I'll explain in a little bit. It's been shown to be very effective with kids with ASD. So with cognitive behavioral therapy, we're looking at this for really higher functioning ASD kids, because the bottom line of it is you've got to be capable of monitoring your thoughts and communicating them. If you're capable of doing that, then and really communicating the automatic thoughts and understanding that, then we can make this work with you. Okay. Okay, so we've talked about the different things that CBT does to work with this. Now, it works to treat anxiety very well. Now, according to the DSM, we're not even supposed to diagnose anxiety disorders with autism spectrum disorders. It's a little bit of a strange thing because, as Dr. Acosta said, they're present, and we know that they're present. It's more that the DSM has this little thing that's attached to every diagnosis that it's not better accounted for by something else, and so in there it says that the autism spectrum disorder accounts for the anxiety disorder. For us, it doesn't really work that way. And for me, I know that when I get an evaluation that has the communication of the different disorders, that's much more helpful for me. So, so things like generalized anxiety disorder, separation anxiety disorder, social phobia, these are the types of things that we can see with this. And obviously OCD is another one that we see with autism spectrum disorders. As Dr. Acosta said, I mean, we've seen study after study that shows that just about everybody with an autism spectrum disorder has some level of anxiety. There's a lot of studies that connect that. And research has shown that CBT is highly effective with treatment of adults with autism spectrum disorders and comorbid anxiety disorders. There's actually been studies that show that it does really, really well with that. I'm going to talk a little bit about why when I get to depression now. Okay, so CBT to treat depression in young adults with ASDs. As Dr. Acosta said, mood disorders they're frequently comorbid. A lot of reasons for that. There's a lot of things associated with social rejection and the realization of the difficulties that you're having that can lead to real difficult times in somebody's life. And as we're moving forward with ASD people, and we're getting into later adolescence, you start to see a lot more awareness of the different things that are going on, and the difficulties that they're having become a lot more apparent to them, and a lot of times there's some depression with this. And again, CBT has been demonstrated to be effective in treatment of depression in adults with ASD. That's studies that show that CBT is most effective. Now, CBT is right now is as research-based psychotherapies go, it's really the strongest. This is something that we can very clearly define in most disorders, especially anxiety and depression in everybody. So it's been good to see that the research is coming back that with autism spectrum disorders that we're also seeing that it's really effective with these guys as well. Elements of depression, and actually really this is anxiety as well. This is this is back to the automatic thoughts and distortions of thinking. These are just a couple of them that we see very frequently with depression and with anxiety and ASD. Is what we call dichotomous thinking. That's black and white thinking. That's when we're using a lot of always, never, everything, never, nothing. The things that are the real extreme words. That's the automatic thoughts that pop into your head. Like I'm always going to do this wrong. And like you do something wrong, and the thought that pops into your head is, I always do that wrong. And the idea is that with this, if we work on challenging those thoughts, is what the validity of those thoughts are. Because if you're saying that in your head, then that's what you're believing, and that's affecting your feeling about things, which affects your behavior, and then you end up with issues with anxiety and depression and things like that. And then catastrophizing is a big one with ASD kids. Catastrophizing is what it sounds like. It's taking something that's not such a big deal and making it the end of the world. And we see this a lot with the ASD kids, where they will where every minor thing that goes wrong turns into a major meltdown. And working with the thinking that goes along with that, the things that they're telling themselves, the attributions that they're making about the event. That's really the biggest thing with this in terms of managing this and improving some of those things. Other points of focus with CBT in young adults with autism spectrum disorders. Cognitive flexibility is a big one. This is a common thing that these are all things that we deal with other people, but theory of mind not so much, but cognitive flexibility definitely is one. With autism spectrum disorders, obviously the rigidity is a big issue. I mean, that's it's something that we have to challenge, and that working on the ability to see things from different angles and to be able to understand that your perspective is not the only perspective is a really big piece of treatment with this, and that's something that that we get into, and actually talk about that later as a challenge to therapy. Because there was something that you went bad about that, right? I remember we talked about that.
I think you addressed it.
Okay. Okay, so I'll get there.
Mm-hmm.
Okay. Impulse control, obviously a big issue. This is the ability to monitor what you're saying and put some thought into things that you're doing before it just comes right out and happens. That also goes into emotional regulation, the ability to tolerate frustration, and that's very tied into the types of things that you're saying about the things that are going on, the types of attributions, things like that. We also work with, obviously, we're always going to work with theory of mind with these kids. It's like a really big piece of any type of therapy. And then even as part of the cognitive behavioral therapy, as I mentioned, social skills is always going to be a big piece. Okay, some adaptations of CBT for the autism spectrum diagnosed population, ASD population. A lot of times we know that the visuals are really important, and I found this with a lot of kids that I'm working with at this stage. That doing things in a way where they're being shown is like a lot of times much more effective. Now, as Dr. Acosta said, sometimes that's not always the case. So there are some kids that are much more verbal learners, and again, that's really where the assessments going to be useful to tell us that sort of thing. But I find with most kids with ASDs, the visuals are going to be really important. That presenting things in visual schedules and being able to have different things that way. Really, like when you're sitting with somebody that has this, and they've had it explained to them a million times, and they just cannot get can't wrap their mind around this. And then when they see it written out, like you sit there and write it out, you can just see the light bulb go off. It's really a pretty cool thing. It goes with visual rating skills too. This is something that you guys have probably all seen, like in terms of like rating skills for anxiety and rating skills for depression. You know, maybe a 1 to 5 or 1 to 10 or 1 to 100. Doing that in a visual way a lot of times will help. Cartooning is another thing that we use with CBT that's really drawing out the different circumstances and having them think through, like draw out different cartoons of what's happening, what they're thinking at the time, what they're saying, what they're doing, and that sort of thing. And a lot of this involves a lot of use of the whiteboard. That's like really, when you're working with kids in this population, this is we all have it. They always have to do that. Okay, social skills training, another one I'm not going to spend a whole lot of time on because, again, by this point, you guys have all had some form of social skills training. But what I want to talk about really with this is, again, it's like the idea that maybe have had that the idea that they've had social skills groups for so long. I mean, really, are they going to continue? Like, they're going to be 40 doing social skills groups? And the answer is maybe. The idea with this is that social skills training is programs designed to teach appropriate behaviors in a variety of social contexts. Now, this one is really for all ranges of function. And this is something that pretty much all ranges of function is the impairment, and some form of social skills training is going to be needed. And as they're transitioning, again, with the idea that the demands of a 18, 19, 20-year-old are very different than the demands of even a 14, 15, 16-year-old. So the idea is that even at this time, there's going to be different things that they're going to have to learn. And again, the difficulty with generalizing skills and just adapting, learning new skills on their own, is like a lot of times it's impaired. So this is something that's for all ranges of functioning with ASD. This is done by either a psychologist or a master's level therapist, which is an LMHC, or like a licensed mental health counselor, or a licensed clinical social worker. And it can be done in an individual setting, but as we know, more commonly we see this in group settings with the different types of groups. Okay, so what do we do with that? What we're aiming for is we're attempting to recreate real life circumstances, and then we use modeling and instruction to teach necessary skills to handle those circumstances appropriately. So the idea is that we're getting them into a setting where some of this can be done like right there in the moment, and they can profit from actually managing different circumstances in the moment as it's going on. Now, a lot of times this will involve in vivo what we call in vivo circumstances in the community. This is where you practice part of the thing that's going to go on in the office, and then you take the kids out bowling and have them implement some of the skills that they learned in the office, so that it's not just the idea with that is that it generalizes better to different settings if they're able to practice these things in different settings. So the social skills training, the difference with kids in this range versus the younger kids is we're going to be facing different, we're going to be addressing different issues. Things like what to do on a job interview, what to do in a dating situation, social gatherings, parties, the expectations at parties. This is really important for all ranges of functioning really. I mean, you think about like a kid that's going away to college and is now being taken out of the home where they're safe and being put into a circumstance where a lot of this is going to be an issue, then that could come up. Yes?
Many years ago, when you would get a diagnosis for your child, they would say your child needs social skills training. The problem back then was where were the groups who was doing the social skills training? Now, flash forward 15 or 18 or 20 years, what is available? How accessible are these social skills groups for these young adults in the spectrum?
That's a really good question, because the reality is that like getting a group of kids together that are in this age range is sometimes it's hard. I know that CARD has great services with that. They have an adult group that runs, it's adult men's group that runs that they handle a lot of these things. And in different offices in private practice, you'll see that as well. There have been different times where in my office we've run groups in this age range. We don't have anything running right now because we just don't have the demand for it.
I'm sorry, so in Coral Gables, actually, we can offer, seniority offers groups that are addressing this age range. So depending on the different offices or agencies with which you're associated, you might find that this age range is targeted. So in our office, in particular in the Coral Gables location, we have up through, young adults who are in college or who are beyond college and who are still, really in need of this type of service and benefiting. And really thrive from being in a safe environment, with a small group facilitated by, someone with experience in this area, and then be able to practice skills with other similar individuals, which will then be able to generalize.
So you're doing role playing in that
role playing. A lot of it is also, for one, be able to empathize with others or be able to get feedback from others about different situations, about what has been successful for them. A lot of times we find, I've sat in on several of these groups, and you find that, they're really just getting the tape from someone else's perspective, or, this is what I did, I don't know why it didn't work out, and the others will just kind of jump in and offer their own suggestions, their own experiences with a particular situation. So you find that a lot of it is just kind of hearing me out, advice giving, and then skills also are developed, which will then carry over. And role play is definitely used.
One of the things that we get with these groups is that it does provide an opportunity for them to make social mistakes and then learn from the social mistakes. Whereas in normal circumstances, where they're not in a group like this, they're just making mistakes, and they understand that something went wrong because people aren't talking to them anymore, or they're getting negative consequences. But nobody's stopping to explain to them what the problem is, like what they did that was so bad. That people will just assume that they know. That you must know that you did that. So it really is a unique situation in these groups.
Right, and we've also had the advantage of having, kind of like the boys group at a certain age and the girls group at a certain age, and we've had events where they've merged, really for the sake of practicing, like Dr. Michael was saying, dating, relationship issues, or just hearing from, female or from the male, how certain things might be perceived. And it is, relatively safe, and we're able to provide feedback, in the moment as to why something was successful or wasn't successful.
know somebody who takes their daughter to a group that meets in Boca. And so now I've heard about a group that meets in Coral Gables. There used to be a group that met in the Broward area, South Broward, and here we are in the Houston City. We know any groups here for the South Broward area since these cities are very right now. And I don't know how many people are involved in this.
We have a lot of people that run groups, but right now we don't have we don't have it set up because we don't have enough people to do it. And I think part of that is what I'm talking about, where the idea is that you get to a certain age and then you don't need that anymore. And it really, like, I would say that more, like, you need it more now than you do at, like, when you're 5. It's like, I mean, the demands are much higher and the expectations are much higher. So it's definitely something that we coordinate. I mean, certainly through CARD. I mean, if there's we're in communication with these guys all the time. So if there's a demand for it, we could set it up in the summer.
There's an aspect of adult rehabilitation going through the state that doesn't exist as readily as it used to, but it still does in some areas. And they called it Job Club. It was the cute little name for it at the time. And what it is designed to do, and it's paid for by the state, is get people together of that age who are involved in the rehabilitation process and going to work and basically doing a social skills training, but with the emphasis on what are you doing in your workplace or in your training place, and it's designed specifically for that. And you could, in a heartbeat, do that specifically with people who are on the spectrum. And it has been done in the past, because I've had in my past life folks that were on the spectrum who I sent to a specific job club because other people on the spectrum were in the job club, and I would just send them off to the same place.
Sure.
So you can easily do that within the setup of a vocational rehabilitation payment situation and have everybody be in one place at one time and do that type of a thing, revolving it around workplace social skills and have it be incredibly beneficiary. I mean, it was to all of my guys, all the time.
Yeah, the Center for Independent Living in Robert. Someone online had a question about the group that you mentioned. Yeah, is that the Asperger meetup? Or,
Yeah.
Okay.
Say hello.
I like that suggestion. Mine is sort of a little broader in terms of, can you give some advice on what do you do with a young adult who doesn't want to go near one of these groups that has the title Young Adults with ASD.
Right.
They may need that and benefit from that. Any suggestions as to how to
Yeah,
deal
it's-
with that?
one of the things that we talk about with the challenges with doing any form of therapy is resistance. I mean, I've heard that a lot. I actually hear that a lot from my kids that are higher functioning. They really don't want to get that tag, and anything that's associated with that tag is tough. Now, it's a smoother transition if they've got somebody that they trust that's not a parent that is suggesting that this is something that would be useful. It's saying something that if I could listen, I understand where you're coming from. They really want to distance yourself from this, but I'm telling you, I've seen that group, and it's like there's really cool stuff that goes on in there, and it's kids that are in your range. Now, the big piece of this is that now when we set our groups up, it's not just based on age. That's not the way that it works. It's best to have kids that are in the same range of functioning working together, because they're on our profit better from that, and it's easier for a kid to get into that sort of group. And a lot of times it's something as simple as saying, look, can you just do me a favor, just do one. And if you don't like it, then if you don't feel like it fits, then that's fine. We'll, no harm, no foul, anything like that. But I'm telling you, I really think that you're gonna get into it.
Revolving things around work behaviors, money that you're going to earn,
Sure.
those kinds of things are incredible incentives for everybody at that
Right.
age range, specifically for folks that are, feeling like mom's wants me to go out and go to work. I have a book rehab counselor who would love to close my case as successful. Oh my God, what am I going to do? And those kinds of things, and calling it those things, are so much more palatable than treatment-oriented type
Sure.
things. It's also a recognition of the person's changing life, and that this is an adult thing to do. And that just makes a world of difference.
Right, I agree. It's a matter of, I think, involving the young adult and really providing some feedback as to what their goals are, immediate and more long-term, and knowing that this is a means of accessing those goals, whether it be through attaining a job, or even if the motivator is to make money for their, to make their own purchases for items that are of their interest. Regardless, it's what's getting them in, and once they're there, generally, they do enjoy being in a setting where they realize that it's with other individuals who are, similar, who might have faced similar challenges, and it's just a nice environment to be in.
You also mentioned the frequency of depression and anxiety coupled with the underlying diagnosis. As psychotherapists, how proactive can you be in communicating with the psychiatrist in terms of if you feel that maybe there needs to be a change in medication, adjustment of medications to deal with that? Because I found a lot of resistance. There's this line, and the psychotherapists say, "Well, I'm not an MD," and communication wasn't necessarily very good between the psychotherapist and the psychiatrist, and it made it very difficult for parents to constantly be addressing.
I think that, at this age range, it's going to be, as clinicians, in the back of our minds, that most probably, with individuals who are on the spectrum, the likelihood is that there will be features of depression or anxiety. From our own experience, I think I can speak for you, we do like to have frequent communication with the prescribing psychiatrist or doctor, whoever it might be in that situation. And generally, in my own experience, I think Dr. Macarone's as well, if there is an indication that an individual may benefit from a change or supplement of another medication, then, we get on the phone and make that call and really convey to them our concerns and the reason why we feel that another medication or the addition of another medication might be helpful for this individual.
To address that, I think that it depends on the psychiatrist and it depends on the psychologist. I think the reality of this is that there are certain people that will get into that whole thing of, there's a line, I'm over here and you're over there. My experience with that is that that's extremely detrimental to the patient, and that the best doctors that I've worked with, they don't do that. It's like the idea of this is that this isn't about who knows more. It's not, because that's really then about the doctors and it's not about the patient. And what I found is that I know that there are certain psychiatrists that we work with that are very receptive. In fact, they tell us that it makes their job easier because they see the patient so infrequently. They see them once a month, whereas we may be seeing them once or twice a week. And they can, if they keep a good line of communication with us, if there's a problem with side effects or things like that, that's the first thing that I'm going to do is contact the psychiatrist. If they're willing to hear it, that I know something about the side effects and I know what to be looking for in different types of medication. So it really does depend. But I think that in choosing who you're working with, it really is a big issue. It's part of it is do they understand what goes on with autism spectrum disorders, and then the other thing is will they collaborate?
If you have an adult patient who's
Yes.
technically age majority, and that patient says to you, I don't want you, I won't give you permission as a psychotherapist to talk to my psychiatrist. Does that happen? Is that allowed, or do you say, well, I'm the psychologist, I'm going to do it? investigate.
No, we can't.
We can't. We have to
You're bound by
respect
that.
that, yes. If the legal age of consent is 18, we consider on a case-by-case basis if the individual is, I guess, mentally competent in terms of making decisions for themselves, but if we deem that they are, then it's really up to that person to make that decision for him or herself, so we have to respect the wishes
But I'll tell
of the
you,
individual.
in that circumstance, when that has come up, it's pretty infrequent because generally speaking, like especially now, what I see more of, I see more from the field from both sides, a willingness to collaborate, especially on this type of thing. Because the reality is there's plenty of research that says that collaboration works, and so so the people that are resisting it, there's not a really good reason to resist it. So by the time they're young adults and they're getting to us, they've already been through that. They've already been through the fact that their psychologist will talk about their psychiatrist. Oh yeah, I know Dr. Like things went well with Dr. Kari this week, and so they know that we've been talking to each other about it. Things like that. So it's in that case, though, I would make a very strong case to the person as to why that's not in their best interest. That if things, and even to the point where we have things on our release of information that say you can talk to them about this, and this, but you cannot talk to them about this, and this. And I'll say I'm totally okay with that, but to at least be able to communicate about the things that I'm seeing in terms of medication is really going to be useful for you. And generally speaking, I would say I can't think of a case where I've gotten resistance for doing that. Any other questions? And I said that I wasn't going to talk about social skills. Yeah.
Yes, you earlier mentioned, Dr. Acosta, that ASD and Tourette's syndrome. So I recently went to a workshop and they said, what's the difference between having a tic or this kind of behavior and self-stimulation? Because most of the time, these are people tending to have self-stimulation. So where do you draw the line between which is which?
For Tourette syndrome, there are a number of different criteria that are met. Diagnostically speaking, Dr. Macker referred to the DSM, the manual that we look at to determine the criteria for a different disorder. For Tourette syndrome, it's going to be it can be quite technical in terms of the frequency of the tics and the presence of both motor and vocal tics. I think the importance is to determine really the triggers for the tics and the purpose that they serve. For Tourette syndrome, for the most part, they are involuntary, which I think can distinguish it from, in the case of autism spectrum disorder, the self-stimulation. Many times it's for a specific reason, and there's a real purpose that's derived from it. So I think in that sense, it can give us a little bit more diagnostic information in terms of differentiating. But for both cases, when it is a more clear-cut case of Tourette syndrome or another motor tic, for example, as well as for self-stimulation, many times the manner in which we treat might be similar. And they might both be aggravated by certain factors such as anxiety or other symptom stressors. Exactly, it might exacerbate both of them.
That sounds good. Yeah, we have more. But if there's any more questions, by all means. Not much. You guys came right into the right time. So the challenges, I talked a little bit about challenges that are specific to this, and you guys actually hit on some of these. The ability to establish rapport is a big thing, in having that sort of the connection. This is a big thing for therapy in any population. It's especially difficult for in the ASD population, just because of the difficulty a lot of times with being close with people and understanding closeness of relationships. So that can always be an issue. Cognitive rigidity is a big thing that we talked about before, and a lot of times that can be a case where as you would ask, where a phone call, where if I'm saying that that therapy is being impeded by the inability to get unstuck from something, it's a lot of times where my first move is going to be to say, not my first move, but say, worked on this, but the next move is going to be to say, listen, I think that that it's something, some kind of medication is going to be useful in this, and then they put in the following with the recommendation to the psychiatrist. And then I talked about the family and caregiver involvement. This, I put that in there as difficult because a lot of times kids that are, when I'm seeing a quote neurotypical 20-year-old, there may not be, I may not be dealing with issues with the family, but a lot of times with these kids we are. And so then into early adulthood, we're dealing with things like resistance of authority, and where the line is for that. I mean, when you got a kid that's 21 years old and is still getting curfew or is still getting certain limits that are put on them, that could be a really big issue that comes into play. Okay. Questions? Any more questions? You guys started a pretty good job. The timing is perfect.
It is perfect.
You asked the questions right at the right time.
I had a question. Oh, I'm sorry.
Oh, hold it, pause.
One question was, I know a lot of times I talk to parents and, yeah, I'll get a call that, they've been in therapy for 2 months and they haven't seen any change. And I know every case is individual, but what should be, I guess, the expectation when someone goes into therapy as far as what's, the amount of time, how the frequency, what's really needed to see a change? I'm
going to give a real psychologist answer on that and say it depends. It really depends on the level of functioning, and the biggest thing I would say that influences that is how quickly the person's able to establish rapport. That the idea of rapport is that I trust that you're going to help me, and that you and I are going to be able to work together in a way. I'm sitting on the patient side and saying, I trust that you're going to be able to help me with this. And when there's difficulty with establishing that slows things down, because then the therapy becomes about making that happen, about gaining the trust first. And sometimes that can take a long time. Sometimes that could be 2 months, and I haven't said one word about the behavioral things because I'm working very hard on getting this person just to know that I'm going to be consistent with them, and that they're going to be able to trust that I'm on their side and that I'm in their corner, which can really sometimes take a long time. And then sometimes I'll get, yes, absolutely. And then sometimes I'll get the parents saying, look, you're not doing anything. Nothing's going right, and I have to explain that, like, you're going to have to be patient with this because this is where we are with things. The expectation maybe that I'm just here to like work for the parents, or there's a lot of trust things that can go on with that. So,
well, kind of related to that, I mean, because I work with a lot of parents that obviously feel like their adult needs therapy, but the adult may not feel like they need therapy, but they show up in your office. Yeah. What's your approach working with someone who might not be there of their own free will? I mean, how do you work around that? Is that productive, or is that like something that they shouldn't even bother?
I think it should be discussed, and I think initially it's important to acknowledge, just the fact that, I know that you may not be here because you felt that it was, important, but, kind of let's make the most of the current situation. And, I think in just having a conversation and really treating the individual as an individual and getting to know him or her, I think really the fear of what therapy really could be, once an individual, sits in front of us and, the conversation happens or an interest in them is expressed, I think they begin to ease up a bit and realize that, there may be something beneficial that can come out of therapy.
Yeah, we all work with adolescents in a bunch of different populations, and that's like a big one for attack. No matter who it is, they come in and say, the first thing is that they the most frequent thing I'll get is they'll come and sit down and the mom will say, she said she's not talking today. She's not going to say a word. And then within 2 minutes, they're talking about the things that are going on. And so it really, like, a lot of times can be that. You're just going to sit and wait. And a lot of times it happens quickly. They realize quickly, like what Dr. Picasso was saying, they'll get in and just see that it's not such a big deal. But sometimes it does take longer, where they just have to sit and deal with the fact that they're having to come to therapy, and that it's really not as bad as they think it is. They're coming to the realization that this is not the worst thing in the world. Really, we need to come and sit and not talk for a little bit for 45 minutes or an hour, and that's it.
Well, I like earlier you mentioned the idea of, talking to the client about, or a parent talking to their child about, just trying something once, or maybe you talking to the client. And so I was kind of curious, I think that's a great approach for maybe getting someone to start therapy. I was curious if you have suggestions for parents who feel like my, child or adult really needs therapy but is refusing to go. Do you have any suggestions for how they could talk them into it?
Bribery works really well. That's like saying that it's, we joke with that, but the reality is saying, I have seen a lot of kids where the parent will say, look, I know you really want this, I'm having a hard time with like making that work, but I know that going to therapy is something that you're really against, but I really think it's a good idea for you. If you'll go to therapy, then I will make this work. And it kind of works something out that's like the beginnings of a behavioral plan anyways. Yeah. And so doing something like that, but then, there's other times where even with the resistance, a lot of times these kids they'll do it anyways. They'll say that they're not going to do it, and we just say, well, I'm going to make the appointment, and we're going to go. And that's like that's a lot of times the bark is bigger than the bite, and once the time actually comes to get there, then they go. And again, the hope is that once they get there, they realize it's not as bad as they think it's going to be, and that maybe even in the first session they get something that they didn't think they were going to get, and they get some investment in an area to get back in.
I think along those lines, the resistance is expected because it's something new, and we know that with this population, anything new is unfamiliar, potentially involves, certain risks or threats. So I think kind of getting over that hump, and again, as we've, reiterated, realizing that it's not that bad, but it's that initial resistance to anything that's going to be different or unfamiliar is usually, what's leading to the refusal to attend.
That's a great point.
So I think, I guess just to sum up, a lot has been done in this field probably since, most of your children were diagnosed, and still so much more continues to be learned. I think, this is probably, maybe one of the first groups or generations of adults, have come to the point of being diagnosed as children that are really growing up and becoming adults and approaching the point where they're making such a huge transition and leap in their life. So I think, I hope that the message has been that, psychologists can really help out to offer support when it comes to a lot of the unknowns. So as parents, you clearly have so much more experience when it comes to dealing with your own children and learning about him or her. Many times that process can be assisted with a psychologist in several different roles. So I guess the message would be, I'm hoping that you've learned about how we can be of assistance to you during that time.
Thank you. Is that it, everyone?
Any other questions?
Can you give us some information about maximizing health insurance benefits to offset some of the costs?
Dr. Mack, could you answer that a little bit better? So the question was with regards to health insurance benefits. I wish Judy was here. But really, when it comes to, for example, an evaluation, at times the costs of an evaluation may be partially covered by an insurance. We frequently have communication with insurance companies to determine the likelihood that they may cover a portion of the costs associated, and likewise for therapy. I'm speaking with regards to our own private practice. So I think that it might be a different response depending on who you're speaking with, but in our situation, many times, just appealing to your insurance company and our office also having communication.
Can you be a little more specific about what you mean? What types of services?
In general, some of these services can be expensive, especially if they're ongoing.
Definitely.
2 or 3 times a week or 2 or 3 times a month. And
Sure.
I know my insurance, it doesn't seem like insurance companies want to cover anything. So,
Oh, yeah, they're like insurance companies are.
That's your job.
They're,
what
no, they're.
percentage of your services are usually covered by insurance?
It depends. Sometimes all of our services can be covered so that the patient is only responsible for a copay. It depends on the insurance.
Yeah, it depends on the type of
policy.
coverage. For example, in our office, we accept most PPO insurances, but we're only in network for Blue Cross Blue Shield, so that's going to make a big difference. If you have Blue Cross Blue Shield PPO, then the co-insurance that you're going to be paying for that is going to be significantly less than some of the other insurances. Now, it also depends on what your insurance will cover. I mean, there's some insurances that we're out of network for that the deductible is really small. And once you hit your deductible, they're paying 80% or 70% of what the services will be. So most of the times I know that we try to make things work. I mean, that's like we understand that the cost of services are very expensive. The evaluations are very expensive, and the therapy is also it's like you said, if you're doing it, once a week, twice a week, something like that, that can build up. And we try to work as best as we can with that. And then if it's not something that we can work with in terms of your insurance policy, the person's particular insurance policy, with our office, I can speak for our office, we'll look at who is on your list of people that are in network for you, and tell you if we know any names of people that we've worked with in the past that do autism related things that we know have experience with that. So insurance is difficult, but we always try to make the best of it as best as we can.
One of the things that might be helpful in terms of combining different services of different folks, both public and private, because that tends to be a big problem as children get older. There's a lot of work in rehabilitation type things that aren't necessarily always covered by insurance, but really necessary. Sometimes it's worth sitting down with the psychologist and saying, okay, here's the kinds of next things that are necessary. How can I combine what you guys can cover with what the state offers, with what CARD might offer, and then combine them? Because I used to do that with people and say, okay, well, this is what the state does, here's what the psychologist does. How can we put that together in a way for whatever period of time the insurance company will bless you and allow you to help with those kinds of needs, and combining the two, because while the insurance pays for the psychologist, if they're going through rehabilitation, make sure that they go to the psychologist while they're going through the rehabilitation, because all the stuff that's going to come up in training and the workplace and all this kind of stuff, if it's not handled in the area of the psychologist who they know, who they have the trust, who they have the relationship with, for sure they will have 10 times as much problems in the rehabilitation. So combining the two has a phenomenal effect in terms of getting the person into the adult rehabilitation process and being successful. In fact, what's real is, for me, having done that for years, the only people I ever had that were successful who were on the spectrum or anything similar to it were people who had ongoing psychological services, not through me and the state, but their own private ones going at the time, with a release of information so that everybody talked to everybody, and the effect was significant in terms of success in training and success in the workplace. It was exponentially better combining those two. So sitting down with all the potential providers and figuring out at what point to bring in the different aspects of it can be incredibly helpful.
So I think,
You
and
said the
thank
thing,
you for that.
write that down.
Right,
You'll be
that-
typing that there.
Yeah, right.
Send me a copy of that, that was pretty good.
Yeah, and I think just to, you're really highlighting the importance of collaboration on the part of all the members of the team. It really should be a team approach when working with, with young adults and individuals in the spectrum, because that really is going to be more of a guarantee for success for that individual. So thank you for that.